now that we have all this good induction treatment, so one of the questions is, what is the best time for transplant, right? So when do you do transplant? What is the optimal timing for transplant? Early transplant versus later transplant. So these are questions that we are still, looking at. Only one study so far has published, the IFM study et al. This was a study that was actually going on in conjunction with the U.S. study, the determination trial, where patients were induced with, the 3-drug regimen VRD for about 4 cycles, and then underwent cytoxin mobilization and stem cells collected. And then patients were randomized to, transplant, followed by lenalidomide maintenance or continuation of VRD for total 8 cycles, and then, maintenance. The difference between the two is that the IFM, they only did maintenance for 1 year, maintenance lenalidomide, whereas the U.S. Study is maintenance, until disease progression. So of course it's over 300 patients in each arm. The French people enrolled their 700 patients in like 2 years, right? Pretty amazing. These Europeans, they enrolled so many patients in very short period of time. And it took the US about maybe 5 to 6 years to finish enrollment. And so the goal was to publish both the same time, but of course such a gap difference in time that the French people published theirs in 2015. And what it showed was that doing transplant early on, within 12 months from diagnosis, was better in terms of the progression-free survival. The 3-year, the median PFS was about 45 months compared to 33 months for patients who did not have transplant. The 3-year overall survival is about the same, about 80%. So it's still a short period of time to follow those patients. I'm sure they'll be doing a long-term follow-up shortly. But the determination study completed almost 2 years ago, and we still haven't reached an endpoint yet in terms of like PFS. So I am assuming that possibly because the lenalidomide maintenance has made such a huge difference, that maybe we may not see any difference between the two, but as of it stands now, early transplant is the way to go, is until the determination trial comes through, or other trials that incorporates maintenance indefinitely. Early transplant is preferable rather than delayed, except for patients who are not transplant eligible, of course. So anything to add to that?
No, I have a small question for you, because I totally agree. Early transplant is the way to go at this point in time. The data all points to that. The one caveat that gets us a little bit in trouble, because we follow MRD all the time after induction. If I have a 70-year-old that's MRD negative, after 4 cycles of RVD, then they ask me, do they need a transplant? You can't detect any, protein in the blood or the urine, and in the marrow, there's less than 1 million cells. What do you do in that scenario? Would you take that person to transplant, or you give them a delayed transplant option?
No, so still the data is not completely there yet, right? And and even I don't even think there's any data looking at MRD negativity and going to transplant. And I know where the MRD is actually being investigated the most is how long we should do maintenance, right? How long will be maintenance? So the SWOG 1803 trial is going to try to answer that. This is that study that's going to go on for maybe 7 years or 8 years, over 1,200 or 1,000 patients, where patients will, are being given post-transplant, short post-transplant will be randomized to Dara-Len versus, lenalidomide. And then Dara will be for 2 years. And then based on MRD negativity, for at least 2 years, they will determine if LEN will be continued versus observation. So for now, you know, MRD is just, you know, something that we use just to put in our, you know, analysis and say this patient is, but we don't really know how to, you know, manage these patients, whether if they're MRD negative, do we give transplant or do it later? You know, I'm sure we're going to be doing those studies. And also with, you know, with maintenance, how long to do maintenance if patients are MRD, you know, negative. So the Alliance trial is also proposing a study on that, and will be interesting, you know, to see. So
Yeah.
much to learn. Yeah.